Okay, just after 12, so I think we'll go ahead and get started. My name is Dr. Milligan, and I'm in the pulmonary section. Many of you have known me over the years for being a pulmonologist, but this year I actually have a new job, and primarily I work in the Feist-Weiller Cancer Center, specifically the Partners in Wellness. And my boss is here, Dr. McClarty, as well as a couple of Jenny and Susan from Partners in Wellness. So we are a small program, but what it is, it's the cancer control and prevention part of the Cancer Center. And that's what we'll be talking about today with screening, specifically lung cancer screening. So these are some objectives, and as a general internist, which most of you are training to be, you'll be referring people for cancer screens, and some of you that may be subspecialists will actually be doing cancer screens, colonoscopies or other things. So it's important to understand about that, because now more than ever, you're being required to discuss a lot of these aspects with the patient before the screening. And then also we'll talk about the lung cancer screening trial itself. But instead of just talking about that, I'm trying to do this in the context of screening overall. So it's really more general knowledge than just specifically about lung cancer. We'll talk about the benefits and harms of lung cancer screening, also in perspective with other types of screening, and then a little bit about smoking cessation at the end. So when we think about eliminating cancer, we often think about therapies such as chemotherapy, surgery, that type of thing. And of course, that's very important. But that's because we're often seeing patients when the cancer is already developed or maybe extensive. But it's also good to think about trying to prevent it or eliminate it early. So an example might be colonoscopy to eliminate polyps that might either be or become malignancy, pap smears to check for cervical disease. And then other screening tests, mammography is obviously one people are familiar with. The CT screening that we're going to talk about today is the newest approved screening test for cancer. And then especially cancer prevention is really important, although perhaps we don't talk about that as much as we should. So a new method there that's been very successful is HPV vaccination for cervical cancer prevention and smoking cessation for preventing lung cancer and other cancers. Now, you might think, well, if we do cancer screening, we're going to prevent all cancers or detect all cancers. But that's actually not the case either. So screening is most beneficial when a cancer develops at kind of an intermediate rate, you might say. It develops slowly enough to be found with screening. If you don't find it, it's going to progress and cause problems, likely death. So there, early detection would be helpful. Also, you're presuming you have a way to treat it and prevent death. But screening doesn't help all cancers. For example, some cancers develop very rapidly. They're sometimes called interval cancers because they can develop between one screen and another, and we'll show examples of that. So they're really too fast to be screened for. And on the other spectrum, some cancers are so indolent, they may never have caused much disease in the first place, especially for certain patients. And those are considered overdiagnosed cancers. The original models, early models of cancer progression look like this at the top. And this actually fit pretty nicely with one of the early cancer models for cancer screening, and that is removal of colon polyps, because polyps typically don't develop cancer for a number of years. So they lend themselves to being screened for. So you have abnormal cells, carcinoma in situ, and then a rather orderly stage progression until you get more advanced cancer, and sometimes that takes a few years. So a lot of other cancer screens were developed on this model, but now it's known that that model really doesn't explain all cancers. So here's the linear model, but we also know that some cancers progress very rapidly and quickly. For example, small cell might be an example. It doesn't follow this slow, orderly progression. Often when you pick it up, it's already stage 4. And then some cancers, on the other hand, are quite indolent. For example, an indolent prostate cancer might fall in this spectrum. So you actually have a early cancer, a stage 1 cancer, but it may stay that way for a long period of time. So you have to take all of this into consideration when you're thinking about screening for cancers. So that kind of leads us to the good, the bad, and the ugly about screening. It's good because if you can remove a precursor lesion in early cancer, then you can achieve a cure, so that's what we want. But it's important to know, and we'll talk more about this in a moment, some cancers can be overdiagnosed, which is not necessarily good, and that can lead to complications sometimes when you're doing biopsies and procedures and therapy for a cancer that perhaps was more indolent, and some patients perhaps didn't need treatment at all. So here's an example of one type of bias, and we're going to talk about 2 or 3 of these because, again, it's important to understand this because nowadays you're actually expected to explain this to the patient. So you want to make sure you understand it yourself. So one type of bias is called lead time bias. So here at the top, if a patient develops symptoms, maybe they have GI bleeding, they come in, we're diagnosed, and then after a period of time they die from the cancer. Now with screening, if you find this early, then that's called the lead time. That makes sense. But if the patient still dies at the same time, maybe they die when they're 65 years old, then you really haven't accomplished much. Their survival is longer because the survival dates from the time of diagnosis, and it might look like you've had an improvement, but the patient died at the same period of time. However, what you're really wanting to achieve is when you can diagnose early, but also provide a therapy that prolongs life. So instead of say 65, the patient lives to 70 or 75, then this is helpful. So if you look at data just by survival, the survival is prolonged. That doesn't always correlate with an improvement in disease-specific survival, for example, cancer-specific survival. So that's more important, actually, in noting a beneficial effect of cancer screening. Now, a couple of other types of bias. One is length bias. And that's when a cancer grows very slowly, and so you have multiple opportunities perhaps to detect that with screening, and that could be a good thing. On the other hand, aggressive cancers are just the opposite, as we talked about. They may appear between screens, and overdiagnosis bias is an extreme form of length bias, and those are illustrated on this little figure. This actually shows it pretty nicely, so let me just take a moment to show this. These vertical lines are screening periods. We could just say this is a 1-year interval. And here a cancer developed, and at the first screen it was either not there or so small it couldn't be detected. And then with a short period of time it grew, it caused symptoms, and actually on this line it actually caused death of the patient before the next screen occurred. So that's the interval cancer, the aggressive cancer. Now the other 2 lines represent cancers that would lend themselves to being screened for. So here the cancer grows more slowly, and here at the next screen at 1 year you have opportunity to detect it before it causes symptoms and before it causes death. Here's another one. It grows a little bit more slowly. So here you have an opportunity to detect it. Here you could detect it by symptoms. Perhaps the symptoms are early, and then you have a screen soon after that if the patient didn't come for the symptoms. So you may have a couple of chances to detect it before it gets bad enough that it causes death. So these are the types that lend themselves to screening where there's a benefit. Now here's the overdiagnosis, which is the extreme form of length time bias. So here it can be screened for. And if you screen, for several years, you might think, gosh, I'm doing great. I found this cancer so early. But here's a cancer that never caused symptoms. It never caused death. The patient may have developed from another cause. And so that's why we call it overdiagnosed, because it may not have represented a cancer that would be particularly harmful to the patient. Now, here's a couple of examples of that related to the lung. This is known as a Peddick Adenocarcinoma. This is the modern classification of adenocarcinomas, and they're often pretty indolent. These are 1-year intervals, and this is pretty faint, so it's hard to even see this tumor, but by here you can see it, and it's gradually becoming a little bit more dense and progressive. These often occurs in older people, and sometimes, but not always, they may be indolent, and the person, depending on the circumstances, might die from something else before this cancer would ever cause symptoms or problems itself. Here's another cancer that, in contrast, would be good for screens. This is a patient who had a little nodule, and this would actually be the time to act on it. But for some reason, nothing was done. And after 2.5 years, you can see it's much larger. Now, luckily for this patient, this hadn't metastasized. He was able to have surgery and hopefully cured. But there's steady progression, and this would definitely have caused metastases and death if it hadn't been treated. So this is an example of a cancer that would be useful to pick up with screening. Just one more word about overdiagnosis before we go on to the lung cancer itself. The way this is detected is often with populations. It's hard to say in any individual patient whether the cancer is really overdiagnosed or not. But if you have a screening tool, and with time you're finding more and more cancers, and you're also finding more deaths from that cancer, then that suggests there's a true increase in significant cancer. But if you have a screening test that picks up a lot of cancers, but the death rate isn't is staying flat, then that implies overdiagnoses. And that's actually been found in a number of types of screening tests, for example, thyroid cancer and others, which were done in other countries, not so much in the United States. So in an individual patient, like I say, it's difficult to know if you have an overdiagnosed case or not, but it's still important to understand the concept. Since we don't know, most patients tend to be treated, but perhaps an example of someone who might not need treatment would be an elderly male with a low-grade prostate cancer and perhaps a lot of comorbidities, and treating aggressively might actually cause more harm than good. Now that, I'm certainly not suggesting for all prostate cancer, but there may be certain circumstances, and that's where I have here at the bottom that informed decision-making is extremely important. So it's not enough just when somebody's 50 years old to send them for this test or that test. It's really kind of important that you look at the patient, see what their condition is, explain them the process, the thinking, and then jointly, and especially with the patient's education, know what should be done as far as referral. Now let's go on to lung cancer. Lung cancer is bad. There's no way to get around that. It's the second most common cause of cancer in men and women, and unfortunately it's the #1 cause of cancer death in men and women. In Louisiana, we're somewhat notorious for having a high rate, #7 for men, kind of mid-range for women, but as far as death rate, #7 for men and higher also for women. So those aren't good statistics for us. Now lung screening, because it is so bad, it's been attempts have been made over the years, and I'm going to summarize all that in this one little slide here. One of the earliest screening attempts was at these institutions back in the 80s, and they found actually that survival was increased. And that may have been because the patients got more attention than usual care, so that was an example of lead time bias. But cancer-related mortality was not decreased, so this type of screening was abandoned. There's another large trial for several cancers that was conducted with x-rays over a number of years. And recently, when some of this data was analyzed, again, there was no difference in lung cancer-specific mortality. So x-rays didn't help. And then I think a study in the 90s that began at Cornell as one institution, then spread to other institutions, utilized CT screening. They were one of the first groups that used large trials of CTs and found that you could detect lesions early and cure it. But there was a lot of controversy because it wasn't really a randomized trial, and some people said, this is not really going to pan out. And so that persisted until recently when the large screening trial was published in the New England Journal. And this established that it was helpful. So the way this was done, it compared CT low dose with X-ray. The patients were followed for several years, although they had only 3 scans. A strength was that it involved over 50,000 patients, which were probably needed to really find the benefit. Adherence was excellent. 4 millimeters was the threshold for abnormality. These were the criteria. It was mid to older age. Cigarette smoking was what they were interested in. They didn't consider other types of smoking. And you had to be kind of a moderate to heavy smoker, at least 30-pack years. You had to be a current smoker or have stopped within 15 years. As you probably know, the longer you've stopped, the risk goes down. So I think they just used somewhat arbitrary of 15 years. It's screening, so you don't want people to have signs of active cancer. If they do, then that's not really a screen. And this is important here, is they have to be healthy enough to have surgery for cure, because that's the best treatment for lung cancer in an attempt to cure. I just summarized a few data points about the patient population. You can see here about 70% were less than 65 years old, so relatively young population. They were underrepresented for Black Americans, male, female about the same, and 50% had already quit smoking. So that's not really our population here, and not the population in a lot of places. Fairly young, healthier population. Here's the data, though. This is the number of lung cancer detected, and not surprisingly, CT found more because it's more sensitive. You can find lots of little nodules, so no surprise there. What was important was the death from lung cancer, and here there were fewer deaths than with chest X-ray, and that was a significant number. The deaths, 247 versus 309, a 20% relative reduction in mortality from lung cancer. So it's not survival that we're interested in, it's lung cancer-specific mortality that's the important number, and that was reduced significantly. Now you might think after studying 50,000 patients over several years, is that all they could achieve, is 20%? Is that as good as they could do? Well, as a comparison, I'll just show you this slide, and this is where we kind of go back and forth with other cancers so you have things in perspective. This is the benefit of mammography over time. As women age, with average risk women, the main risk factor for developing breast cancer is age. So as you do screening, there's less benefit, less decrease in mortality at younger age, but that improves more benefit as you go down. So 50 to 59, about a 14% decrease. 60 to 69, about a 30-something, 33% decrease. So the 20% decrease from lung cancer screening is about the same as you might see from mammography in breast cancer. And this is based on a number of large trials. So that puts it in perspective a little bit. Now, another thing about the screening is that these were the 3 periods. And the scans not only found more cancers, they also had more positive results, which a positive is just something that was suspicious for cancer. So here it was 27, 28, 17, chest X-ray 9, 6, and 5. So clearly more positive results, again, not surprising. But what do positive results mean? Positive results mean you have to chase after that. And now for 3 rounds of screening, almost 40% of the patients had something that was suspicious for cancer. So most of the time that can be followed up by more frequent scans. Instead of waiting a year, you do one at 6 months or maybe 3 months, sometimes PET scans, other things. Of course, that costs a lot of money. But it was found that 96% of the positives were false positives. So that's good in a way, but again, a lot of time and effort and money to chase that down. Even people that needed invasive biopsies, which are not many, 2 to 4%, 73% of the biopsies were benign. So again, most of the positives were false positives. So how does that fall into line with other types of cancer? Again, here comparing mammography, which is a widely used screening test. This again is data from several trials, and it's a 10-year probability of a false positive mammography. So here, if screening started at age 40, there's about a 60% risk of false positives over 10 years. If screening starts at age 50, it's really not much different. It's less if the screening is done biannually, but again, this leads to different things. You might need another mammogram, an ultrasound, other type of test to evaluate that. In some cases, biopsies were done. So the 60% in the lung cancer screening, not too far off from mammography. Now here's a little bit of information about the cancer staging. And what you would hope is what happened, and that is that many cancers were found early, stage 1A, 1B, when surgery could be accomplished. And actually, you continue to have 1A and 1B patients as time went on. They didn't decrease. And that kind of makes sense because once the carcinogenic process is there, you've been smoking for 30, 40, 50 years, then that field, so to speak, that damaged epithelium is going to be there for a long time, and people could develop cancers then probably for many years later, or otherwise they would be at risk for that. So even though the study was done at 3 years, that's when significance was found, and you did need to screen further. This process is ongoing. But what's troubling, although not surprising when you think of cancer, is what we talked about before, the development of the interval cancers. So here after 1 year, you still had, here after 1 year, you still had some 3B and stage 4 cancers. Again, after the last screen, some more 3B and 4 cancers. So they obviously weren't there at first. You would have seen them, but they're developing within a year and advancing quickly to late stage, which most likely could not be cured. So screening is good, but again, just to reinforce, it doesn't detect all the cancers. Treatment we alluded to. Most patients with the early stage were treated with surgery. And that brings up the obvious point: patients should be agreeable to surgery and fit for surgery. And doing the program here, what we typically get and we encourage are people that are heavy smokers and meet the criteria, but there's not much thought into somebody really suitable for surgery. And that's something we kind of take on ourselves, and I'll talk more about that in a minute. But since that's the cure for lung cancer, and that's what was found to be helpful in the trial, that's what we're trying to accomplish. And it's worth thinking about that when you send somebody for a screen. Are they able to tolerate the optimal treatment for that cancer, whether it be colon cancer, breast cancer, lung cancer, whatever. Now here's something else that's interesting. CAT scan is a powerful tool, but what we see here are the people that had negative screens. In other words, they had something that wasn't felt to be suspicious. There was a little dot or a little scar or something there. But over time, about 4% of the patients that had negative screens actually did end up developing cancer. So we've talked about overdiagnosis, false positives, but you can even have some that develop with a negative screen. So again, the limitation of this type of screening process. We talked about overdiagnosis. There's been different analyses of that for this trial. And here in this analysis, they felt that about 20-something percent, 9 to 34% of non-small cells might be overdiagnosed. To me, that seems a little high, but the analysis is complex, so I really can't comment scientifically. Not surprisingly, the more indolent cancers, bronchoalveolar cell type, many of those may have been I've overdiagnosed. That I can understand. Again, referring back to mammography, just looking at data from multiple trials, it's estimated that perhaps 10 to 20% of cancers might be overdiagnosed, often from ductal carcinoma in situ in older women. Now, nearly always this is treated because, like I said before, you don't know with an individual patient, is that going to be an overdiagnosed cancer or is that going to be lethal? And so you don't like to take that chance with any human being. But when you have large studies, large populations, then some of this falls out, and it is used to establish policy and consideration and should be discussed with patients. Just a few other points about the data in the trial, and I think this is helpful. And this is pretty typical for the type of thing you would see in any type of screening. So the objective was preventing death from lung cancer. So of every 1,000 patients, you had 3 or 4 fewer deaths. But you had a lot of false positives, 375. This is kind of the average patient. About 40 of those needed a biopsy. Some needed surgery. Some had complications from the surgery. So a lot of people are screened for the few that are helped with the screening. Now, I'll just talk a little bit about some of this. The requirements of the lung cancer screening program. They actually are requirements. Medicare has given these requirements. And since this is the most recent type of screening that's been approved, they really used a lot of lessons that were learned from other types of screening. And I think it's a little bit more rigorous, and I don't know if that will pretend that other screening programs will have to be changed, but it's just kind of instructive to learn this because, the screening recommendations do change every few years. So you have to have certain eligibility criteria. Nearly all screens, you need a decision aid. I'm not sure how often that's used, but here it's required that you use it. You need a reporting system. Here, uniquely, we talk about smoking cessation. You need a multidisciplinary program. There's guidelines on the dosing of the scans. And interestingly, you have to submit the data on all the screen patients to Medicare, not just the Medicare patients, but all patients, because obviously they're continuing to look at the data to see if it's going to pan out in the general population as opposed to the largely university-based study that was published in New England Journal. So eligibility criteria, you'd think that would be easy. But a lot of groups have different criteria. For example, these are the most recent criteria about mammography. American Cancer Society, women aged 40 to 44 should have the opportunity to screen, but begin screening at 45 to 54. But the Preventive Services Task Force said to go ahead and start screening at age 50, although younger women could have the opportunity. And this created a lot of controversy when this came out, because insurance often uses these guidelines to approve payment. And when somebody says, well, you should just wait a few more years for screening, then that can cause a lot of consternation. The same can be true of other types of cancer. For example, with prostate cancer, there are numerous recommendations, everything from no screening at all. ACP, limited potential, but if you're going to screen, begin at age 50 to 69. The urology group, again, they recommend informed decision, but here they say 55 to 69. Now, high-risk patients, for example, African Americans, those with family history, you'd screen earlier age, but this is just kind of in general. So you have to think about, which criteria you're going to use when you decide as a physician you're going to go ahead and screen people. However, the same thing with lung cancer screening. I'm not going to go through all this, but you can see there's several. What we use here are the Medicare guides, which are almost identical to the Preventive Services Task Force, except the age cutoff is about 3 years younger. Now, again, I mentioned about good health. The goal of finding lung cancer early is to do surgery because that's the best chance for cure by far. And here I thought these statements were helpful, and you could apply this potentially to other types of cancer. For example, colon cancer, or those that might require major surgery if a cancer was found. So screening may not be appropriate for those with substantial comorbid positions, especially if they're at the upper end of age of the screening. So if you have somebody in poor health that's 75 years old, should they have a colonoscopy? Should they have a lung cancer screening study? People with serious comorbid conditions may have net benefit, no net benefit, or less benefit than other people, and consider stop screening when their health limits their life expectancy. So for this program, we see the people back in 1 year. If their health has changed, dramatically worsened, then screening may not be important at that point. And that's why we're required to see them when we do the ongoing screening, is partially to assess their status and their surgical status if necessary. I'll just summarize this slide to say that although there's a requirement to do this, there's no standard way of doing it because it's a brief screening visit. It's often performed by a nurse practitioner or physician assistant. There's no testing. There's really not even any exam. You're just reviewing the chart, talking about smoking cessation, explaining the program, but you're not really doing a pre-op assessment. So you have kind of limited ability to do it, and so this is a point of question and some consternation until people can figure out how best to do this. Now, the importance of the shared decision visit. I presume that those of you that refer patients to screening will go over a decision aid. There's a lot of them for any type of cancer. Some are fairly brief. But for the lung cancer screening, there's this whole list here. I won't read to you. But this is actually required that we discuss this with the patients when they come in, Most of the patients I see have less than a high school education here. They're super nice people, a lot of them pretty smart, but you have to discuss a lot of concepts, false positives, overdiagnosis, adherence, willingness to undergo further tests, surgery, radiation risk, et cetera. That's a lot to go over, and again, that's why I'm reviewing it with you to help you with this. How to discuss lung cancer risk. I've found this to be helpful. And there are often risk prediction models for many types of cancer. For example, breast cancer, that's widely used, Gale model and others. Maybe not used so much in other types of cancer. But this one is available for lung cancer risk. And it looks at age, ethnic group, education, presence of COPD, prior cancer, family history of cancer, and of course, smoking. And luckily, this has been incorporated into an easy-to-use web page. This one is from University of Michigan, but it uses this complex formula based on many thousands of patients to go through and calculate this. So they have these for other types of cancers, and you can actually just do this with the patient when you're interviewing them to get this information, and then it's a nice visual. So here, this person over 6 years, which is how long the data was valid for. Their risk for developing lung cancer is about 4%. So low risk considered less than 1, intermediate 1 to 2. So they're here in the darker color, although not extremely high. But this helps the patient kind of get a grasp objectively, not just some doctor telling them, but based on a little bit of science, what their risk is. And after going through this is one of the last things I discuss. Then I go on to smoking cessation. And I think it kind of helps prompt people a little bit. They realize, well, gosh, this is kind of serious. I have a risk of cancer here, and maybe I should consider smoking cessation. Now, the other thing that it does, it shows the benefit of screening. I showed you some of that data earlier, but it's able to calculate how many fewer deaths there would be in the screened population. So here, since the risk is not real high, 8 fewer deaths in the screened population. And furthermore, it talks a little bit about the harms of biopsy, false positives, and other things. So this is very nice, and you can go over it with the patient, write this down so they'll have it in the future. Now, using this kind of numbers, I'll just show you a couple of examples. And again, you're probably familiar with this with other types of screens, whether it be mammography or other things. And I think it's helpful to give the patient some perspective to say, go for screening, you're 55, what is the pros and cons about that. So in a typical patient from the lung screening trial, this is somebody 62, 1.5 packs a day for 35 years. 250 patients would have to be screened. And with that, about 4 people would be saved from death from lung cancer. Although 16 patients would have died from lung cancer. So I point this out to the patient too. The screen is helpful, but it's not 100%. In fact, again, more people still die than are saved. So that's kind of sobering. Again, we think screening, gosh, this is great, I'm going to save everybody, but that's not really how it is in most of these types of screening. This would be somebody that just barely meets criteria, the youngest age 55, 30-pack years, so they're just the minimal criteria. Here you'd have to screen 1,200 to prevent just almost 1 death. Here's somebody at the other end of the spectrum, older, 2 packs a day for 55 years. You wouldn't have to screen as many, and you save more, although still nearly 50 people don't survive despite the screening. So it's quite a spectrum, as you might expect. Higher risk, you save more, but still more die. Lower risk, not as much help, have to screen a lot more people. So when people, the statisticians and epidemiologists look at this data, this is the type of thing they just look at to decide what the cutoff points are. What age should screening start? When should it stop? What are the risk factors? Are the risk factors high enough to justify screening? And this is done for all the different types of cancer. Now the next thing, just briefly, how do you manage the lung nodules? So again, like the decision aid or eligibility criteria, there are many different options. And I won't go through all of these, but As a pulmonologist, we often use the Fleschner guidelines or CHEST for nodules. The Comprehensive Cancer Network has a set of guidelines for nodules. But what's popular now is the LUNGRADS system. So I'll just mention this briefly because you may be getting reports or knowing about this, so you'll know what LUNGRADS means because that's fairly new. The LUNGRADS is kind of takeoff on the BI-RADS system for mammography. So you can see how these things progress. This has been very useful. So the people that decided about lung cancer screening decide to incorporate the same type of format. So here are the higher numbers, 4 and 5, are the ones that are at risk that need further evaluation for mammography. So a same type of number system is used. And this relates the score to what the follow-up should be, the chance of cancer, and how many in the population. Now, the emphasis is on minimizing false positives. But of course, with that, you may miss some cancers. For example, one thing that was done is for solid nodules, they chose 6 millimeters rather than 4 millimeters in the lung screening trial. And there's a whole literature about which size nodule you choose. But this is what was chosen by the LUNGRADS. So most patients, 90%, are going to either have a normal score 1 or a very small nodule, very low likelihood of cancer. So you do the follow-up at 12 months like you would have done even if it was normal. If it's a bigger nodule, you may need follow-up at 6 months. If you're having a 4, then there's much higher risk of cancer, and those are the ones that probably need to progress to further workup. You're all familiar with a solid nodule. You've seen nodules like this, I'm sure, many times. And there's a guideline for each type of nodule. There's not just one type of lung nodule. So here's the guideline for the solid nodule. I won't go through all this. But just to point out one more thing, as well as the size threshold, it's what happened on the initial screen, what was seen on the initial screen, and then what was seen on the follow-up. For example, if this person had a follow-up at 1 year and there was a new nodule less than 4 millimeters, then that would be the threshold for the follow-up. So the follow-up threshold is different than the time 0 threshold. So that makes it a little confusing. Hopefully the radiologists are keeping up with that, and all we have to do is look at the score to know what should be done. So just so you know, it's different numbers, different thresholds for the first scan versus follow-up scans. If this was a nodule of 6, it may have been there for 20 years. We don't know. But if it's new and it's 4 to 6, that's something that's significant in the last year, and so we would judge it differently. Now, the other types of nodules, you've heard of ground glass opacities. They can represent all types of things, many not serious at all. But sometimes they can be cancers, like the Peddick Adenocarcinoma we saw. And then there's a part solid nodule. So it's got a solid component, and then the periphery is ground glass. These are the least common, but they have the greatest risk of being cancer. 20-30% of these may be cancer versus a much smaller number of these. So again, there's different guidelines for the part solid ones. I won't go through all that. And for the ground glass ones. The ground glass ones, they use a larger threshold, up to 20, before they consider it significant, because even if it was a cancer, it may be more indolent. And so there's different criteria for following those. So just so you know a little bit about the criteria and what this LUNGRADS means. Now, also required by Medicare is requirements for the radiologist. They have to read CAT scans regularly. They have to meet their CME requirements. And the place that does the CAT scans has to be rigorous in making sure that it really is a low dose, because that's a strong requirement. And you have to report all the parameters of the CAT scan. You have to keep those and report it. And again, it's sent on all patients, not just Medicare patients. Now, the last few minutes, I'll talk about the other important part of lung cancer screening, and that is smoking. Because after all, about 90% of lung cancer in this country is caused by cigarette smoking. In other countries, there may be more contribution from biomass pollution and other things, but cigarette smoking is also common in developing countries as well. So we see here that Louisiana, in the area where we live, is second worst, unfortunately not second best. But as far as the incidence of cigarette smoking, we're here 21 to 25%. Kentucky, West Virginia, tobacco growing states are the highest. So that's not good. But what's been found, actually, is that when people come in and get their assessment and they have a bad news on the lung rads, and that actually kind of scares them a little bit to consider smoking cessation. So here, if a person has a positive CT that's really suspicious, the odds ratio for stopping smoking is lower, which is good, versus somebody with a more normal scan. And also beneficial, not quite as much, if it's just suspicious but stable. So it's actually been recommended to use this information to not exactly scare the patient, but to say, this is serious, and we need to get serious about your cigarette smoking. And actually, that's found to pan out. Now, some other rather striking data from the lung screening trial. There's been a number of ongoing papers from different aspects of this. And this is just really amazing. Looking at the cancer-specific mortality of current smokers versus former smokers, the mortality is much higher, or is higher in current smokers, as well as all-cause mortality. So that's not so surprising. But here, if you look at the people in the control arm, which are those with chest x-rays, so they weren't really being screened effectively because chest x-rays haven't been shown to be helpful. But if they had just stopped smoking for 7 years, and then you looked at their survival, there was a 20% mortality reduction. Now, if you remember, that was the positive result from the whole screen in the first place, 20% mortality reduction in the lung cancer screening trial. But you could achieve that just in the people that had stopped smoking for seven years. So isn't that amazing? And if you look at this, people that had stopped smoking for 15 years, that was the maximum that someone could still be in a trial if they'd stopped 15 years before and had a lung cancer screening, then 38% reduction in lung cancer-specific mortality. That's twice the benefit of the whole group. So that really shows the critical importance of smoking cessation for these people as well as for everybody. The task force recommended that screening with low-dose CT should be viewed as an adjunct to tobacco cessation interventions. Essentially what they're saying is the way to get people to come in for their smoking cessation visit is to screen for lung cancer. And of course you do that, but the emphasis should really be on smoking cessation. And I think that's really, really true. You just saw the data. Because smoking cessation is not only for lung cancer, it's for all your cardiovascular disease and COPD and other cancers that are caused by smoking. So it's required, and I think it should be, that smoking cessation should be an important part of the discussion when you have your informed consent. Now, just briefly, a couple slides about our program. Multidisciplinary programs are needed, and I'm not sure they're here, but I think Dr. Halde, Calangeri, and Ferraro for help with interventional procedures when we have diagnosis, as well as a whole other staff, thoracic surgery, oncology, radiation oncology, and our friends at Partners in Wellness who really help manage this. Because it takes a lot to track the patients, decide when they need follow-up, and et cetera. Basically how this works, we get a fair number of referrals, but if you have a patient, this is the consult Partners in Wellness lung CT, and our nurse Susan Lloyd or one of her associates contacts the patient to confirm the history. We found that the smoking history in the record is often very poor and inaccurate. So somebody doesn't want to come, especially a long way off, and to just find out that, gosh, I didn't smoke enough and we can't enroll you, or there's some other factor. So she calls every person, discusses it with them, gets a good history, make sure they understand, and then we schedule them. We go over the visit. We do this over at the Feist-Weiller building, so we're able to get this scan the same day, and then we arrange follow-up based on the results. Now soon we're going to be putting out a flyer. University Health is our partner with this. And of course that's essential. And so they've approved this flyer, and we'll be posting it around some of the clinics just to help people remember the criteria and hopefully we're going to have this in EPIC too, so you can just see if you want to do a referral, what are the criteria. So make it much easier to select the proper patients. Just one slide on the data. We're just kind of getting started this year. We've had 65 patients so far, half male, female, 52 pack years average, so kind of heavy smokers. If we do the should I screen calculation, it's about 6%. So all these were in, this is definitely in a higher risk group, not the lower or intermediate group. And most of the patients, as you would expect, either had no nodule or small nodules, but we're starting to get some that have larger nodules that are getting PET scans or other workup. Reimbursement, it's not a lot. For the visit, it's for Medicare, it's less than $30. That's to go over all the elements that we talked about. And of course, when I do this, I spend time reviewing the chart beforehand because it's hard to do it just in a brief visit, so I know more specifically what to ask patients about. The biggest payment for Medicare is for the actual CAT scan itself. Luckily, with the way insurance is right now, most insurances, because it's a screening test, just like mammography, pap smears, colonoscopies, there shouldn't be a deductible or copay. I hope that stays that way. But this only covers the screening. So if nodules are found, people need other studies, CAT scans, biopsies, or whatever, then that's paid in the usual manner. This is just for the screening visit. So just a couple of 3 more slides and we'll be done. I've mentioned this before that I'm not sure with other screenings how much this is done, but Medicare is really collecting ongoing data with all the patients to see if the population at large in the United States has the same positive outcome as the people in the lung cancer trial. And there could well be adjustments made to the programs if necessary. And this last thing I think is obvious, and we really should be putting a lot of effort into tobacco cessation. Now this helps put this in perspective and actually is a little bit of data. This is published recently, and the authors are from Emory, CDC, and some of them serve as advisors to Medicare. And what they looked at is a large population, about 200-something thousand people, in what's known as a health and retirement study population. Those are people approaching or in retirement. Some, but not all, have Medicare already. So if you look at that database, which is here, compared to the National Lung Screening Trial, what you see is that people were older, 30%, 70 to 74, 36%, 60 to 65. And remember, the lung cancer screening patients were much younger. More people college educated, 31% versus 11% in the Medicare, this retirement study population. Somewhat more smokers. More people with diabetes, 24 versus 10%. Heart disease, 33 versus 12. And stroke, 12 versus 3%. So an older, less healthy population. And these are the patients that are now eligible for screening. Here's the survival of the National Lung Screening Trial patients with a life expectancy of 21 years. And these are different breakdowns for the other patients, 55 to 74, 55 to 80, which is the Preventive Services Task Force age range. And then all these patients didn't have Medicare, but if you looked at the Medicare eligible patients in HRS, then their 5-year survival was lower. This is age 55 to 77, so if you're 55 and you have Medicare, that suggests you have some kind of disability or a problem. So again, this is a less healthy group, and so their mortality would be less. But obviously a difference here as far as health. Now, how will that affect the results of the trial? We don't know, but certainly people are looking at that. So their conclusions were that the U.S. population eligible for lung cancer screening is probably less likely to benefit from early detection because they face a higher risk of death from competing causes. They're not saying it should be done. They're just pointing out the obvious. But the next thing I would agree with, and that is it highlights the need for smoking cessation interventions to help with these people. And the last couple of slides, I'll just present some more general information about smoking cessation. This has nothing to do with the lung cancer screening trial, but this is a study published by epidemiologists looking at the benefit of smoking cessation on overall survival. And these are people that may have died from lung cancer, other smoking cancers, COPD, heart disease, anything that's caused by smoking. So it's a general effect of smoking. And what is nice is they broke it down by age groups. So here, for example, are some patients that may have been in the lung cancer trial, for example, as compared to never smokers and those who continue to smoke. If you stopped at age 55 to 64, you gained about 4 years of life. And again, most of this was the smoking-related causes of death. If you stopped earlier, 45 to 54, you gained 6 years. And these are for younger people. Stop 35 to 44, then your curve is almost superimposed. You gain 9 years. If you stop very young, you probably hadn't smoked much in the first place. You gained 10 years if you lived until age 80. So that's really striking. And I don't think most people would want to lose even 4 or 5 years, much less 9 or 10 years. And so I just put that there to encourage you to think about this. Every time you see somebody, ask about smoking and encourage smoking cessation every opportunity. I saw a patient, I think it was just this week or last week, who had stopped smoking a few years ago in the program. And I always ask them what worked, so I can use that to help me. And what they said is their resident, their junior doctor, had just pleaded with them so much and had a lot of empathy that they just felt they had to stop smoking. And they did. So if you put the effort in, that can really make an impact with a lot of patients. So I was really impressed with that. So I think with that I'll end, and thank you very much.